Hello, everybody. Welcome to today's webinar on the topic of transplantation across humoral barriers. My name is Heidi Aguiar, and I am part of the Alliance team, and we welcome you to today's webinar. Just before we introduce the moderator for today's webinar, I have a couple of logistic items to go over with you. So this webinar is being recorded, and so all of you as participants are muted. So if you have any questions for the speaker, just click on the icon in the bottom left-hand corner on that blue icon and type in your question so it comes through on the chat feature. And we will hold the questions till the end for the speaker, but we will moderate them at that time. Coming up next week on May 31st is our annual Brain Death Declaration webinar that's geared towards physicians. So registration is still open for that. It is a 90-minute webinar, so just make sure to plan for that time. And feel free to go ahead and register for that at braindeathwebinar_May 2017. Or you can go to our Alliance website and go under Education and select the webinar series option, and you'll find it there. Coming up on June 13th, we have our next donation-focused webinar, and this one is on creating lasting legacies through donor memorials. For this webinar today, we are offering 1 SEPC credit and also 1.2 nursing contact hours, courtesy of Iowa Donor Network. Now, everybody who's listening to the webinar, and I know many of you are listening in groups, are entitled to these contact hours. All you need to do is make sure you complete the evaluation. So if you are in a group, whoever registered for the webinar will be the one receiving the email with the evaluation link. Please make sure to take note of everybody who's in the room and forward that evaluation email to them so that they can complete their evaluations and receive their certificates. Those are automated via email back to the person completing the evaluation. Please note that for nursing, you have 14 days, and that's not business days, that's 14 calendar days. And then for SEPC credits, you do have 30 days to claim your credits. So at this point, I would like to turn it to our moderator for today, Savita Inyang. Oh, I'm sorry, Savita. I should have asked you how to pronounce your last name. Can you please tell me how to pronounce your last name?
Iyengar.
Okay. I'm not sure I quite caught that, but hopefully everybody else did. Savita is a member of our transplant webinar faculty, and she very kindly helped to organize this webinar for today and will be moderating. And she is the manager of quality and compliance at the Mayo Clinic in Rochester. So Savita, I'm going to turn it to you to introduce our speakers for today.
Thank you, Heidi. It is my great pleasure to introduce our 2 speakers today. I just want to let everybody know that Dr. Stiga, who is our second speaker, is in surgery currently and hopefully will be joining us. But I'll go ahead and get started. Our first speaker today is Dr. Carrie Shinstock, who is Assistant Professor of Medicine at Mayo Clinic in Rochester. She's a practicing transplant nephrologist with a research interest in kidney pair donation, faster cross-match kidney transplantation, and antibody-mediated rejection. Dr. Stiga is Professor of Surgery at Mayo Clinic and has a wide research interest. His research applies to all patients with kidney disease, including those with diabetes, polycystic kidney disease, and high blood pressure. His basic science studies can be applied to patients with diseases of immune system, including autoimmune disorders such as lupus. These studies apply to children and adults of all ethnic groups, but especially to those with high rates of kidney disease, such as African Americans and Native Americans. His research areas include antibody barriers to kidney transplantation. Many renal transplant candidates, approximately 1 in 3, have antibodies in their bloodstream that react against kidney transplants. These antibodies can severely damage or even destroy a kidney transplant. Dr. Stiga's laboratory tries to understand how these antibodies are made and has developed novel and sophisticated methods of testing the actual cells that make antibodies in humans. They've also developed several new agents that prevent the antibody formation and antibody damage. Having introduced our two esteemed speakers, I'll now hand it over to Dr. Shinstock.
Thank you. So today we're going to talk about transplantation across humoral barriers. And, essentially I'm going to talk about transplantation in the setting of donor-specific antibodies. So the goals of my talk are twofold. I'm going to do some basic immunology information, talk about the basic tissue typing techniques. I also hope at the end of this talk that you all learn how to interpret the flow cytometric crossmatch and single antigen B test. These are really important tests to actually measure or detect antibodies. I'm going to define highly sensitized and also let you know what CPRA means. And lastly, there's a clinical part of this talk. I'm going to talk about the options for the sensitized transplant candidate and describe the outcomes of positive cross-matched kidney transplant in the modern era. To put this all in context, I'm going to start out with a case. And this is a patient that I've actually seen, but he's not much different than patients I'm sure you've all seen in your dialysis units or a transplant clinic. This is a 42-year-old male. He has a past medical history of IgA nephropathy and previously had a kidney transplant, but unfortunately it failed from rejection and non-adherence. He had stopped taking his medications. And he has been on dialysis since approximately 2006 and has been on the waiting list since 2008. This patient is lucky enough that he has a potential living donor, but as you can see here, he unfortunately has a positive cross-match towards this living donor, and his calculated PRA is 99%. And this patient sees you and he has lots of questions. Why haven't I been called for transplant? What is CPRA? What does it mean to be highly sensitized, and what are my options? And I'm hoping that my talk will help you answer these questions for the patient. So to start out with the basics, I want you to understand how we determine a patient's tissue type to begin with. So a person's tissue type is determined by the genetics of our major histocompatibility complex, and there are class 1 and class 2 major histocompatibility antigens, okay? Now, there are some minor histocompatibility antigens that are sometimes important, but the main ones to pay attention to are class 1, which are HLA-A, B, and C, and class 2, which are HLA-DP, DQ, and DR. And whenever you have a donor or a recipient come for an evaluation, you start out by getting their tissue type or know what their class 1 and their class 2 antigens are. Now, some recipients, unfortunately, the recipients I'm talking about here, actually develop antibodies towards these different tissue types. Now, what leads to the development of these antibodies, or what leads to sensitization? Because sensitization essentially means the development of antibodies in general, not necessarily donor-specific antibodies, but just antibodies towards these HLA types. This can happen in the setting of a previous transplant, which was the case in our patient, pregnancy, blood transfusion, and there are some who feel that certain bacteria and viruses can also lead to sensitization. For example, if a patient is infected with a bacteria that has a chemical structure similar to an HLA type, there's some feel that that can also lead to antibody formation, but this is less described. And I don't want you to focus on this for this talk. So how do we measure these antibodies or detect them in the setting of transplantation? And there's actually several different methods, and this is an exciting area of transplantation because our ability to actually detect antibody has changed significantly in the last 10 years and has essentially revolutionized transplantation in some ways. So there are cell-based cross-match assays. These were have been used for several decades. In the last 10 years, we have started using the flow cytometric cross-match assay. The cell-based cross-match assay usually gives you a negative or a positive result, but the flow cytometric cross-match assay actually gives you a number, so you can get an idea of if the cross-match is low or if it's high, okay? And this is what is usually used, but not all centers use the flow cytometric cross-match. And lastly, in the last 10 years, we have been able to actually detect the actual donor-specific antibody, or have some specificity towards antibody. And we now do some solid phase anti-HLA testing. These are single antigen bead tests, and there are various methods to do this. But again, this gives us a specific HLA antibody, whereas these two tests just tell you, hey, there's an antibody or some reactivity present, whereas this test actually tells you that there is some donor specificity. And this is a schematic of the testing methods. And in all cases, you have the recipient serum that contains the actual antibodies. And in the cross-match testing, you add this serum to donor lymphocytes. In the cell-based cross-match, you add some complement. This makes the test work better. And you mix the donor lymphocytes in the serum. This gives you a positive or negative CDC cross-match result. Again, this was used much more previously. It's not used as much now because you actually need a lot of antibody to give you a positive CDC cross-match. In the flow cross-match, you add the recipient serum with the donor lymphocytes, then you add this fluorescent conjugated anti-human globulin, and then you put all of this together in a flow cytometer, which is a special lab instrument, and that will also give you a positive or negative result, but it will give you a range or a number, so you can again know if this is a high or a low cross-match result. And then lastly, I think what is the most interesting is our solid phase assays, where you put the recipient serum on a series of beads. Each of these beads has a different HLA antigen on it. You will also put this fluorescent marker. Again, you go through an instrument. This is a Luminex instrument that's similar to a flow cytometer, but at the end of it, it just gives you the specific antibody result. Okay, this may be more than you are interested in knowing, but I think it's important when you learn about these tests to know where they come from. And what's important is that all of these tests give you information, and there is actually a degree of risk. So this is not a, yes, this person is at risk and this person isn't at risk. There is a degree of risk depending on the positivity of these tests, okay? So you might have a patient that has a negative flow cytometric cross-match and negative single antigen B test. This is where most patients are, and they're at the lowest risk. And then you have patients that have positive single antigen B test, positive flow cytometric cross-match test, and then even a positive CDC cross-match. And these patients are at the highest risk from a transplant standpoint. And with the new flow cytometric cross-match testing, in addition to the single antigen B test, you can see that there are patients in different categories or different risk levels. Now, with all tests, there are some limitations. And I think the main point to understand is that there are limitations to the test. I don't necessarily expect the allied health providers to know what these specific limitations are, but just to know that there are limitations. So first, these single antigen B tests are not a direct measurement of antibody. So you're not really measuring antibody, you're just measuring the fluorescence of the test. And that helps to explain some of these other limitations. The other thing is there can be something called a prozone or a saturation effect. And what this means is sometimes patients have so many antibodies that it actually saturates the test and you get an inaccurate result. Usually you'll get a low MFI. So MFI is the readout on the single antigen B test. And you might get a very low MFI in a patient with a unexpectedly high positive cross-match, and you might not understand what that means. But what that means is that there is so much antibody it's saturating. If this is the case, you would want to avoid that transplant. It would be too dangerous. Also know that there are lots of different single antigen bead manufacturers, and the ability to measure certain antibodies is different depending on the different company. And also sometimes the antigen, the HLA antigen on the bead is actually denatured, and that can give you some false positive results. Again, you don't necessarily need to know all of the limitations if you're not in tissue typing or do incompatible transplantation, but understand that there are a lot of limitations to this test. So how is sensitization estimated? And in transplant, we look at something called the CPRA. And CPRA is essentially an estimate of the proportion of the deceased donor population to which a candidate has HLA antibodies. And this is expressed from 0 to 100. And what I tell my patients is that, let's say they have a CPRA of 90%. That would say that 90% of the time you are going to have antibodies towards the donor. Or in other words, that recipient is going to have antibodies towards 90% of the population. Okay. Now historically, before we had the single antigen B test, they did this based on cross-match testing instead. But now we use the single antigen B test. And the way that CPRA is calculated is this calculator. You can all find this calculator online. I have the website below, and you look at the patient's single antigen B test results, and whatever anti-HLA antibodies you think the patient has, you just put this into the calculator, you press calculate, and it will give you the CPRA for the patient. The caveat is that every transplant center has their own threshold of positivity. So at Mayo in Rochester, we have a pretty high threshold for what is positive in terms of antibodies. So we use an MFI of 2,000 as our positive in doing this calculator, whereas some of you might be in transplant centers that are a little bit more conservative, and you might use a lower value for positivity. Okay. And also know that there's certain antibodies that are not included in this calculator, including DP and DQ alpha. And this is important because a large proportion of highly sensitized patients, or those patients with a CPRA of greater than 98%, have other antibodies that are not accounted for in this calculator. So let's go back to our case after we've talked a little bit about the basics of antibody testing. And again, we'll see that this person has a positive cross-match, and they had a CPRA of 99%. So a really highly sensitized patient, a patient with a lot of antibodies. But it's actually a fairly exciting time for transplantation in this area because there are a lot of options for patients who have an HLA incompatible donor, just like our patient has. There's kidney pair donation, there's the deceased donor waiting list, and there's a new allocation system. And lastly, in some cases, you can go forward with an HLA incompatible transplant. And I'm going to go through each of these options in more depth. I think that kidney pair donation is one of the more exciting aspects of transplantation at this time, especially for highly sensitized patients. And what this essentially is, where you have donor-recipient pairs that are incompatible. You might have a simple case where you have two incompatible donor-recipient pairs, and you essentially do a donor swap and can do a transplant in that way. But you can see here, there's actually lots of ways that we can do kidney pair donation. There's the simple two-way exchange, but then there can be also very complicated, not necessarily complicated, but there can be long chains. There are several different kidney pair donation programs. Some of them are single center, and there are also very large national programs. Most of you are aware of the National Kidney Registry, and other very prominent national kidney pair donation programs, but there are also many single center kidney pair donation programs. For example, at Mayo Clinic we have a 3-site Rochester, Scottsdale, and Jacksonville kidney pair donation program, and we've also been very successful. And now most programs do a combination of some single center and also use some of the national programs to optimize the chances for their patients. But unfortunately, many highly sensitized patients, like the patient in my example, are still waiting for a transplant despite kidney pair donation programs, unfortunately. So this is data from our own kidney pair donation program. And here you'll see each of these dots represents a patient who was in our kidney pair donation program. The open circles represent patients who are transplanted, and the closed circles represent patients who are still waiting for a kidney transplant. And you can see here that patients with a CPRA greater than 90% often wait a really long time to get a transplant, whereas if they have less than 90%, most of those patients are transplanted within a year. And we use this when we counsel our patient about their different options. And I know this is single center data, but this is not different than what is happening in even very large programs, as well. They're becoming saturated with very highly sensitized, difficult to match patients. And not only do sensitized patients have trouble occasionally finding a compatible donor in kidney pair donation, but so do some blood incompatible patients. This is data from the Johns Hopkins group, but I find it very interesting. So what they're looking at here is different combinations of donor-recipient pairs based on the blood type of the donor and recipient, and they look at the percent of the time where that recipient is going to find a compatible donor in the pool. And you see here that if the donor and recipient are blood type O, the recipient has a CPRA less than 80%, and there are 100 pairs in the system, they have about a 53% chance that they will find a donor, a compatible donor. But the chances are much worse if you have an A donor and an O recipient. In that situation, only 13% of the time there's going to be a compatible donor. And if the patient is sensitized or has a CPRA of greater than 80%, you can see that only 1% of the time they're going to find a match. And unfortunately, even if you increase the pool size tenfold, there's 1,000 pairs, that doesn't really increase the odds very much. So the main point is that kidney pair donation is wonderful, but it is not the right option for all patients. So because there's some limitations to the kidney pair donation program, we have implemented a hybrid of incompatible transplantation and kidney pair donation. So from 2009 to 2013, we were really optimistic about what would happen to our patients with kidney pair donation. We did very few positive cross-match transplants during that time, and we only transplanted about 11% of our patients with a CPRA of greater than 95%. But since then, we have started doing more incompatible transplantation and desensitization, and now we transplant about 29% of those patients. So, you know, I've talked to you about kidney pair donation. Now I'm going to talk to you about what it means for your sensitized patient to be in the deceased donor waiting list. And this is exciting because there's now a new allocation system for highly sensitized patients, but also in Europe and Canada they have programs to optimize transplantation for these groups. So before the allocation system in 2014, patients with a CPRA of greater than 80% would get 4 extra allocation points. That's all. And you can see it was 4 points whether you were CPRA 80 or 100. But after that time, you can see there is an exponential increase in the amount of points that sensitized patients get. So now if you have a CPRA, and it's not shown here very well, but if you have a CPRA of 98%, you have about a 17% chance of, or I'm sorry, you get 17 extra allocation points. If you have a CPRA of 99, you get approximately 50 points, and now if you have a CPRA of 100%, you get about 200 points, and that's about 200 years of extra waiting time. So for the sensitized patient, their time on the waiting list in some ways is a little irrelevant. You can see here in all of the allocation schemes, the most highly sensitized patients get priority. They even have priority above the 0 ABDR mismatch kidney transplant. But despite all the points that highly sensitized patients get, unfortunately the new allocation system is really not the answer for all of these patients either. This is data that was published approximately a year ago showing the impact of the new allocation system. And this top line shows the number of patients with a CPRA of 99 to 100%, so the highest CPRA. And there was about 8,000 patients on the list prior to the allocation system change. And even after a year of implementation, there was still 7,000 patients with a CPRA of 99 to 100%. And that's despite, this bottom line here shows you the percentage of the transplants, of total transplants that were given to these patients. And right after the allocation system changed, 17% of transplants went to patients with CPRAs of 99 to 100%. Now it's leveled off to about 12% of transplants, but you can see that there's still a lot of sensitized patients on the list. So the allocation system is wonderful, but it's not the answer for all patients. And this is even the case in the Eurotransplant acceptable mismatch program. The red line here is showing you the patients that are added to their waiting list, and the blue line are patients who are transplanted. And you can see there is still a gap between the patients who are waitlisted and transplanted. So because kidney pair donation and the deceased donor allocation system do not provide or do not give a timely transplant option for all sensitized patients, I hope to convince you that in very select settings that there may be a role for incompatible transplant. This is positive cross-match transplant or transplantation in the setting of donor-specific antibody or single antigen bead positivity. So going back to our case, note that our sensitized patient does have an incompatible living donor with a flow cytometric cross-match of 230. Okay. And one of the reasons that I even bring this up is because there is fairly compelling data that if an incompatible transplant is done in an appropriate setting, those patients actually live longer than staying on dialysis. This is data from the Johns Hopkins group. This is single center data that was published in 2011. And you can see that patients who received desensitization or a positive cross-match transplant lived longer than those patients who remained on dialysis, okay? This study was redone, but it was done in a multi-center cohort. Mayo contributed a lot of patients to this cohort, and again, they confirmed those results that patients who receive an incompatible transplant have improved survival as compared to whether they stay on the waiting list. But this doesn't mean that incompatible transplant is not without risk. These patients are at risk of antibody-mediated rejection. This is, again, data from the Mayo group, our group. This data is now, about 7 years old. And what you can see here is that patients who have a positive CDC cross-match at the time of transplant have about a 50% chance of having an early acute antibody-mediated rejection, and with the improved flow cytometric cross-match testing, about 30 to 40% of them might go on to develop an early acute antibody-mediated rejection. Now, some groups provide therapies such as rituximab and IVIG at the time of transplantation, and their rate of antibody-mediated rejection is similar at about 40% when you take all comers who receive a flow cytometric positive cross-match. But as most of you in transplant are aware, that these early acute, sometimes devastating antibody-mediated rejection episodes are not the whole story. There are patients who don't have any acute antibody-mediated rejection or very early antibody-mediated rejection, but several years down the line their graft fails because there is this slow, smoldering, gradual eating away at the kidney from a chronic antibody-mediated rejection. And this is a picture of this chronic antibody-mediated rejection, otherwise known as transplant glomerulopathy. And at this time in transplantation, this is the real problem. There's an unmet need. We need therapy for this chronic antibody-mediated rejection. So we actually looked at, so I want to go back and say, if you recall, there's improved patient survival if they receive incompatible transplantation, but that doesn't mean that those grafts don't fail. So here we looked at our death-censored allograft survival in patients who received a positive cross-match transplant, and this was all comers. And the rate of the death-censored allograft survival was about 70% in those patients who had a positive cross-match, as compared to about 90% over 5 years in those patients who had a conventional or negative cross-match transplant. But again, if you think back to the initial part of my talk, there are a lot of new sensitive donor-specific antibody testing methods. And a lot of the data previously was in regarding patients with very high levels of antibodies. But now we have very sensitive single antigen bead test and flow cytometric cross-match testing, and it's a little unclear how patients do in these yellow-orange zones. And so that's what the next portion of my talk is about. So I actually looked at the outcomes of our patients who had a very low positive flow cytometric cross-match. If you recall, if you do that flow cross-match, it will actually give you a number, so you can determine if it's a low positive cross-match or a high positive cross-match. So we looked at all of our patients from 2007 to 2014, and we had control patients. We had 54 patients that had some single antigen bead positivity only, but they had a negative cross-match. We had 35 patients that had positive single antigen beads, and they had a low positive cross-match, and I define low as less than 200 as the flow cytometric cross-match. And then we had 43 patients that had a high B-flow cross-match. And in this study, I defined high as greater than 200. In terms of the baseline characteristics of our patients, most of the patients in the DSA group were female. If you recall, pregnancy was a reason for sensitization. Also, I think there were younger patients in the sensitized group as compared to the non-sensitized group. I also want to point out the desensitization methods here. So most of the patients in the single antigen B positivity only, so just with the single antigen B positivity, they just had donor-specific antibody negative cross-match. Most of them did not receive any special therapies or desensitization. Even in our patients that had the single antigen bead or positive DSA testing, in the low positive cross-match, actually most of them had no extra therapy either. And that's important to realize. Only in those patients that had the highest flow cytometric cross-match did they receive therapy. So the vast majority of these patients, actually 80% of them, received eculizumab at the time of transplant. And that's really important when considering these results. We followed these patients about 4 years. And what you can see here is that only those patients in the high B-flow cross-match group had a lower graft survival. So even those patients with low-level DSA or low positive cross-match, they had very similar death-censored allograft survival as compared to the control patients. Now this was only up to 5 years, but it's important to realize that doing a transplant in the setting of a low amount of donor-specific antibody is often safe for the patient and may be a reasonable option in certain circumstances. And again, only those patients in the high cross-match group had lower allograft function. So we looked at iothalamate clearance in urine protein, and again, this was similar in those patients with no donor-specific antibody in a negative cross-match, and even those patients with a low cross-match. Only the patients with a high cross-match had a lower iothalamate clearance and more protein over our follow-up. Now, like things, the devil is always in the details. We also looked at surveillance biopsies in these patients, and although the allograft survival was reasonable in those patients who had a low positive cross-match, you can see here that their rate of antibody-mediated rejection was actually higher. Okay, so we looked at biopsies at 1, 2, and 5 years. You can see in the groups with increasing DSA, there is more antibody-mediated rejection, and it also increases in time. So even in those patients with low positive cross-match, about 50% of them have chronic antibody-mediated rejection at 5 years. And that's important because this chronic antibody-mediated rejection is associated with long-term allograft loss. But interestingly, I'm going to go back to this slide and show you that even some patients here that had no antibodies at the time of transplant went on to develop chronic antibody-mediated rejection. Okay? So we looked at those patients and tried to figure out some risk factors. Now, most of you know that these patients can develop antibodies after transplant, and that's bad too, but that wasn't the whole story here. So what we found is that patients who had an unexplained early antibody-mediated rejection, but also, and this is, I think, the most interesting part of this, was that even patients who were sensitized had a risk of antibody-mediated rejection, even if we were not able to detect the antibodies at the time of transplant. And this was detection with a very sensitive test and experienced tissue typing. And this suggests that these patients are at risk for rejection, even if they have negative single antigen B test. Now, earlier I was showing data just from our own positive cross-match transplantation cohort, but similar data has been presented by others. This is another paper that was published this year in the American Journal of Transplant. This group only looked at patients who had a negative cross-match. So in our group we looked at all comers, but this group only did negative cross-match transplants, and they looked at just patients with a little bit of donor-specific antibody. And like what we found, if you have low levels of donor-specific antibody but negative cross-match, there's no difference in allograft survival at 5 years. Now, what I also think is important to take into consideration when thinking about these transplants is that a living donor transplant has better allograft survival as compared to a deceased donor transplant. So some of you might have been listening to the earlier part of my talk and showing you that there was more chronic antibody-mediated rejection or reduced allograft survival in those patients who received a positive cross-match. But when you think about, just getting a living donor transplant gives you some advantage too. And this is at least something to think about when you are counseling your patient about transplantation. So I know there's a lot of excitement about the deceased donor allocation system, but even a perfectly matched deceased donor transplant still doesn't have the same survival as a living donor transplant. So this leads me to, what do you think about when you're considering a positive cross-match transplant or incompatible transplant? So the first thing I think about is the patient's sensitization. And if you recall, patients who have a CPRA less than 90% are usually going to get a transplant through the kidney pair donation program. So if you have, I would only think about these incompatible transplants in that setting, okay? You also think about the degree of DSA in cross-match positivity, because if you recall, only those patients with the highest flow cytometric cross-match or DSA, they had the worst outcomes. So you also will think about that. And then I think about the patient's time on dialysis. Dialysis is associated with a lot of morbidity and mortality, so if somebody has been on dialysis for 10 years, it may be worse to get them off of dialysis. I also think about an access to kidney pair donation. At Mayo in Rochester, we're very fortunate to have access to a very good kidney pair donation program, so we have more options. But if you're at a center that doesn't have access to kidney pair donation, then your options are limited. It's also really, really important to think about the transplant center resources. So to do incompatible transplant, you need a really experienced tissue typer. Remember, there are a lot of limitations to the single antigen B test and to the cross-match testing. So you need somebody to help you understand that. You need access to plasmapheresis. You need to be able to do very timely allograft biopsies. And you also need access to adjunctive therapies if possible. This meaning rituximab, eculizumab, bortezomib, IVIG, some of the other therapies. And then lastly, it really depends on your own expertise. Although the outcomes with donor-specific antibody positivity and a low positive cross-match are, pretty good, it's still really important to consider your own expertise, because there's still a risk of antibody-mediated rejection, and you need to know how to deal with that. So this leads me to what we do here in Rochester. This is just an example. If we have a patient like the patient I described before with an incompatible living donor, they all go on the deceased donor waiting list. They all go in our kidney pair donation program for 4 to 6 months because we want to find them a transplant with the lowest level of antibodies. Now, if that patient has a CPRA of less than 90%, we usually just keep them in kidney pair donation, again, because they'll likely find a donor. But if they have a CPRA of greater than 90%, and they have a B flow cytometric cross-match less than 300, we will at least consider a positive cross-match, given the improved outcomes with a living donor transplant and the reasonable options for a positive cross-match transplant. And I'm hoping that in the future we have some other tools, better desensitization therapy, and other ways to determine the pathogenicity of certain DSA, but we're not quite there yet. So in conclusion, I want to let you know there are lots of antibody detection techniques with various sensitivity and specificity. The most sensitive is the single antigen B test, and it has some limitations, although it's very good. Secondly, sensitized patients have more options than ever before. I think there is a lot of hope for patients with a CPRA of greater than 90%. But it's not the answer for all patients. So I don't counsel my patients who are in that range that they're going to find a donor in kidney pair donation, or they are going to get a call, because we don't know that. And as I've shown you, there are still a lot of sensitized patients on the list. And lastly, the risk of incompatible transplant is reasonable in very select settings with experienced personnel, and this depends on the single antigen bead results and the cross-match results. Thank you. I welcome any questions.
Back to you, Heidi.
Thank you. Thank you, Dr. Shinstock, so much for a very thorough and excellent presentation. I think we all learned a lot. For those of you who are participating, this is the time that we're able to pose your questions to Dr. Shinstock. If you have questions, in the bottom left-hand corner, you should find a blue icon, a chat icon. If you just click on that icon and type in your question, we'll be able to pose a question for you to Dr. Shinstock. While the Q&A time is going on, I'm going to have a poll up that for those of you who are listening in a group, if you can complete how many people are in your group, that would be very helpful. Savita, if you can maybe get us started with some of the questions that you have prepared, and then we can see if we receive some questions from the audience.
Okay. So Dr. Shinstock, thanks again for the talk. The first question would be, if a center has no experience with positive cross-match transplantation, how would you recommend that they get started with this practice?
Okay. The first thing I would do is talk with get an understanding of the resources that are available at their center. I would have a long conversation with their tissue typing personnel to gauge their understanding of positive cross-match transplantation and donor-specific antibodies, and I would make sure that they would be willing to partner with you because you need a team to do this. I would also make sure that you have access to a biopsy and plasmapheresis and some of the other therapies available. And then at that point, I think if you have no experience at all, I would first try this donor-specific antibody positivity first and see how you do from that perspective. And then you could move on to low flow cytometric cross-match testing. After the data came out from the Hopkins group about the increased patient survival with incompatible transplant, I received some calls and questions from others about doing incompatible transplant. Now, that data is really reassuring, but I still think that you need people very experienced. Most of these sensitized patients only have one shot, so you have to do it right. But I think it's reasonable to start out with donor-specific antibody and then maybe very low-level flow cytometric cross-match if you have the team in place
Another question for you would be, how would you approach an unexpected positive cross-match at the time of transplantation?
Okay. Well, this happens actually not infrequently in the sensitized population. And what I would first do is talk to the tissue typing expert. We have access to them at all hours, and I would talk to them about what it means. And sometimes they will tell you that there is a little bit of low donor-specific antibody, and in that case, it again depends on the risk tolerance. If at our center, if it is a very highly sensitized patient, they have lots and lots of antibodies, they've been waiting a long time, and it is a low-level cross-match, then we would probably consider going to transplant. On the other hand, if it is a patient who doesn't have a lot of antibodies, hasn't waited a long time, I would probably pass on that.
Any other questions, Hedy, from the group?
I don't see any further questions in the line. All right. Well, Dr. Shinstock, thank you so much for a very, as I said, a fantastic presentation. I really appreciate how deliberate you were in taking us through all of the basics and going into more of the details and what the various options might be for the patients. So we truly appreciate you spending your time with us and sharing your expertise. Savitha, thank you for your organization of the webinar, and to all participants, thank you for your participation today, and we wish you a wonderful rest of the week.